And welcome back, everyone. I'd like to thank our sponsors, Pain BC, the Strategy for Patient-Orientated Research Chronic Pain Network, the Canadian Institute of Health Research Institute of Musculoskeletal Health and Arthritis, the Partnership for the Engagement of Patients with Pain Research Project, or PEPA, and Health Canada. Many of our presenters will share stories and perspectives shaped by their individual lived experiences. The views expressed do not necessarily represent the views of Pain Canada or our sponsors. Remember, these sessions are being recorded and will be available after the conference on Pain Canada's YouTube channel. Also on Monday, many people living with pain joined to share helpful life hacks for living with pain. These hacks will be posted on Pain Canada's website under resources for people living with pain, and will also be sent out with the recordings after the conference. So welcome to the third session for today, Neurodiversity and Pain. Please be reminded that today's sessions will be recorded. We have French interpretation and closed captions available for you. And now I'll turn it over to Jenny. Good luck, everyone.
Thanks, Therese. Welcome, everyone. My name is Jenny Lorca, and I am an uninvited guest and settler of color on the traditional, unceded, and stolen lands of the Coast Salish First Nations, which is colonially known as the Greater Vancouver Area. I am a queer, disabled, self-identified, neurospicy Gemini, and if it's not evident now, it will be evident during this conversation. So neurodivergence has a very strong presence in our steering committee, and it is an increasingly salient topic among the community members that I've had a chance to speak to and interact with. So, and Alex, who you will see in a moment, when they proposed this topic as a potential conference session, I put my hand up to facilitate it because I knew that this was going to be a good one. So just so we have an idea of what we're covering today, I'm just going to put up some slides here. Bear with me. Can everyone see that? Okay. So I'm just going to go through these slides just to show you the discussion pieces we're going to cover, sort of like a visual agenda, and then circle back to introducing our speakers. If it works. Here we go. These are our speakers: Alex Haggard, Lindsay Wolfson, and Caitlin Berner. Desmond Williams, unfortunately, couldn't be with us today. And we know that his wisdom and his presence is woven throughout this conversation and throughout our lives. We're going to go through some selected definitions and some more selected definitions. Talk about our complicated diagnostic journeys. Talk about our experiences with intersection and our thoughts about intersectionality in the context of chronic and persistent pain. And neuroaffirming approaches to clinical management, supported self-management, and community connection. And then finally, we'll leave some room for questions and comments. So now, I know that this topic is vast and multifaceted, and it is impossible to cover it all in the time that we've got. So we at least hope that this conversation will tickle your curiosity bone, perhaps increase your awareness and understanding maybe. And especially for those of you who find yourselves, like most of us on this panel, at the complex intersectionality of neurodivergence and pain. We hope that you realize that you're not alone as it feels sometimes. We totally got you. So let me please introduce these amazing folks who are the architects of this conversation. Alex Haggard. I hope, yes, excellent. Alex Haggard. is an autistic design researcher and patient partner whose favorite way to manage their chronic pain, other than actual medication, is snuggling with their dogs under a weighted blanket with the lights off. Therese mentioned earlier that there was a cracking life hacks session on Monday, and they've got another session on mapping pain research priorities coming up on Friday, and I cannot wait to see that synergy. Secondly, among many things, Lindsay Wolfson is a health researcher, sexual health educator, a master of social worker, and a very good friend. She is known for her ability to spill water on herself and her tendency to run into doors, walls, canoes, and docks. I cannot wear white because of those same things. And spatial awareness, attentiveness, and coordination are not my strong suits either. So I hear you, friend. Caitlin Berner is a registered clinical psychologist who is passionate about health equity for young people living with chronic pain, and who brings her own lived experience of chronic illness and neurodiversity to her work. I know, Caitlin, that you'll be talking about neuroaffirming approaches to care later, and the fact that you are a neurodivergent clinician makes you the perfect unicorn. So thank you and welcome. Just a couple of words about our buddy Desmond Williams, who, like I said, can't be here today. He was instrumental in co-developing this session, and it is to our great loss that he isn't with us. What we will do, though, is provide some of the resources that he would have provided, and so that you can connect with the work that he does, including the Partnership for the Engagement of People in Pain Research's new podcast called, oh my gosh, Living Proof: Experience as Evidence. Please go check it out. Not because I'm on it, but because it's really good. So let's do that. Welcome, friends. Let's start with, before we begin, give me a moment to put up these slides. This is me being as transparent as possible. And actually, Caitlin, how about if I can just invite you to talk about the definitions of neurodivergence, neurodiversity, as I fumble around with these slides, if you don't mind. Thank you.
Sure. So, just so we're all using some common terminology here, and I say this sort of respectfully acknowledging that everybody has their own language for talking about neurodiversity, neurodivergence, and your own individual identities. Generally, what we're talking about in this session when we're referring to neurodiversity or neurodivergence is having a mind and a nervous system that works differently than how society expects. And it's an umbrella term that can include many conditions and identities and diagnoses, including autism, ADHD, FASD, learning disabilities, chronic mental health and substance use struggles, and certain chronic illnesses. And the term was really introduced to acknowledge that these differences are natural variations in human brains, and really positioning society's expectations as the problem rather than considering these differences or natural variations as being something that's wrong or abnormal. And a lot of this movement has really been a pushback against a lot of the terms that had previously been used that had a lot of stigma, a lot of pathologizing attached to them. The term neurotypical is one that we're using to describe having a mind and nervous system that works in the way that society expects and in the way that society tends to accommodate. And neuronormative refers to those societal norms that really privilege and prioritize these neurotypical ways of thinking and being. And this overlaps a lot with the concept of ableism, if that's one that you're familiar with. And on the next slide, we mentioned a little bit about what I said right at the beginning, which is that we really respect everyone's right to self-identify in their own way, and that your language use may differ from ours. And I hope we can kind of all come together and learn from each other around and respect our individual preferences. Some people prefer person-first language. So, for example, saying the person with FASD versus identity first language would be saying that somebody's an autistic person. And this preference differs between people and between and within groups. And in most cases, there is no sort of set consensus on language use. Everybody's allowed to have their own impression and experience of these terms. And there's often a lot that's attached to these terms, depending on how you've been raised, the society that has shaped the way that you see things, and the communities you associate yourself with. And we wanted to briefly touch on self-diagnosis because this is really relevant, particularly in neurodiverse communities, where often access to a formal diagnosis isn't accessible. And this can become especially complex if you're navigating both neurodivergence and chronic pain or chronic illness. So self-diagnosis is when somebody identifies with a diagnosis or label based on their own self-reflection and research. It's not recognized as a medical diagnosis. So often the medical diagnosis is what's required to access certain supports or resources. But the process of engaging and reflecting on your own self-diagnosis can be very meaningful in understanding yourself and in also understanding and reflecting on some of the systems level barriers that might be getting in the way of having access to a formal diagnosis with an informed and affirming provider, and someone who's informed and affirming both on the side of neurodiversity and on chronic pain. So that's some of the language we'll be using today, and hopefully that helps to set the scene a little bit for some of the conversations that we're going to have.
Thanks, Caitlin. Again, you prove yourself to be a unicorn. So let's talk about complicated diagnostic journeys. I know that in the session description that we came up with, we said that, neurodivergent people's experiences with chronic pain may be different from, neurotypical people, which causes complications with respect to diagnosis, treatment, and because we may experience pain differently, or because of stigma or disbelief from healthcare providers. And I know that we each have our own way through learning about ourselves with neurodiversity. And I want to start with Alex, if you don't mind, to talk about your experience. Thank you.
Yeah, and talking about self-diagnosis, I think it is a good starting point for that. I should say my intro said that I am autistic. I am self-diagnosed as autistic. I still remember the first time that I sort of discovered, this was back when Asperger's was a diagnosis, and I first read about Asperger's. This was also before Wikipedia was a thing, and it was a lot harder to find information about things like this, especially growing up in rural Ontario. And I still remember the first time I sort of discovered that as a term, and suddenly it felt like I had a potential explanation for all of the things that are quote unquote wrong with me. And I say wrong because for my entire life up to that point, I think I was around 17 or 18 when I first sort of found that. I'd spent a lot of my life wondering what was so wrong with me. Why did I have a quote unquote temper tantrum when my mother sort of moved stuff around in my room and put it back in a different spot, or when she soaked my hairbrush and left it full of water and it touched my scalp and it felt like I wanted to, sorry, this might be triggering language, but peel the skin on my scalp off in a quite literal way. Why couldn't I handle sudden changes of plans? Why was I the smartest kid in my class, but also people would give me verbal instructions and I wouldn't be able to understand what they were saying to me. And so that was sort of the first time I had this sort of moment of recognition of myself in someone else. Because I spent most of my childhood growing up, I sort of imagined, I had this very elaborate fantasy in my head that I was an alien who'd been dropped off on planet Earth, which I came to learn later is a very common thing that autistic kids think about themselves. And so that was the first sort of moment of recognition of myself in other folks that I had. And then in my late 20s, when social media became more of a thing and I became more active on social media, I started to become more confident about self-identifying as autistic and find a community with other autistic people. And again, it was this process of learning so much more about myself, learning that sort of the episodes I had where I would hurt myself are meltdowns. And learning that there are ways that you can manage your sensory input so you don't get to that point. And then it's still a process of continuous learning. Last year, I went through a period of autistic burnout, which if anyone is unfamiliar with the term, it's a little bit different than how we use the term burnout casually. It's kind of what happens when a neurosystem that is prone to becoming overwhelmed by inputs kind of shuts down, and it can make you more prone to meltdowns, which I think people tend to be more familiar with the term meltdown, but it is sort of, it's when your nervous system goes into overload and it turns into sort of an outward display of extreme distress, which can look like making noises. It can look like hitting yourself or breaking things. But you can also go into shutdowns, which is sort of the opposite when you go inward and you stop being able to respond. And in extreme cases, it can turn into what's called catatonia, which is where you become unable to do very basic things in your day-to-day life. Like you can feel like you need to go to the bathroom, and it can take 3 hours to actually muster the nervous impulses to coordinate your body to get up and go to the bathroom. And I was sort of looking up this, sorry, again, this is going to be triggering. I was looking up on an autistic subreddit, feeling like you don't want to die, but you don't have the energy to live anymore. Because that's a thing that I felt really commonly in my life. And it never seemed like, this is the thing, when you look on forums about depression, about mental illness, about suicidality, it never quite matched what I would be feeling. And finally, I saw someone talking about that and talking about that as a symptom of a shutdown, because it's not that you want to die. It's that you're so overwhelmed, you just can't anymore. And that's your brain's response to like, this is the only other option. And suddenly that clarified a lot of things for me too, because in the post that I found, someone talked about how they'll feel this way and they'll go take a nap and they'll wake up feeling not fine, but better. The suicidality, so-called suicidality, will have passed. And that really crystallized something for me, because I'd had conversations before with mental health intakes where they'd sort of, they do a questionnaire and they ask you to rate the level of your suicidal ideation or depression on a scale from 1 to 10. I'd sort of land around like a 4 or 5, and they'd be like, oh, so you're stable right now. And I'd be like, well, I mean, like it might change in an hour. And they'd always get really weird about that. And I never realized that that's because like, that's not how depression works for most people. That's like, your depression doesn't just kind of flip a switch. And it also doesn't just go away if you take a nap. And so like, again, it's this constant process. Learning, self-diagnosing as autistic has been this process of learning about myself, when so much of myself often has felt like it hasn't made sense in the world. But all of this, sorry, this is autistic brain, a very rambling way of saying I don't have a formal diagnosis. And I've been constrained in my ability to get a formal diagnosis because I mask very heavily, partially due to trauma of also growing up with abuse. And also partially, I actually think my masking, like we always talk about masking, masking is when autistic people imitate neurotypical mannerisms. But for me, it's also it's an echo phenomenon. It's like some autistic people mimic noises that they hear, but I actually mimic affect and mannerisms. And I've realized that because I was having a conversation with someone who had a very heavy stutter, and I started to stutter very heavily, and it was very awkward. And it was at that point that I realized, oh, maybe it's more than just a trauma response. But anyway, point being that I have tried a couple times to get a diagnosis, and I've variously been diagnosed with anxiety, diagnosed with, actually at one point I had a psychiatrist tell me, well, there isn't really a difference in terms of how we treat social anxiety, so there's not really any point in diagnosing me with anything else. I've gotten the very common, but you're too good with language, you're too good at facial expressions, and sort of getting a little ahead of myself into the intersectionality. Like I grew up in rural Ontario, so I didn't have access to psychologists who were well versed in diagnosing autism in people who were not young white cis boys with a very particular type of presentation. But then also feeding into that, being autistic, and particularly being undiagnosed as autistic, has also complicated my access to diagnosis of chronic pain, because I do not perform as good as I am at masking and performing neurotypicality in a lot of ways. I am not good at performing pain in a neurotypical way. I tend to get very calm outwardly, because when I'm in distress, I actually tend to get very calm and like hyperverbal, and I explain things a lot, which also always leads to me being perceived as a hypochondriac who's read a little bit too much of the Dr. Google. So yeah, all of that to say is that I would say my life has been defined by complicated diagnostic journeys and really underdiagnosis. And I've rambled a lot, so I'm gonna throw it back to I think Caitlin.
Caitlin or Lindsay?
Yeah, I can jump in if you don't want to, Caitlin. It's a um and maybe I'll like leverage off. I mean, Alex, thank you so much for sharing so many pieces of your journey and just your lived experience. Um, it it's so it's such a privilege to be in this space with everybody and like to have been able to talk about neurodivergence and chronic pain on and off as we plan for today. Um, for those who don't know me, I think Jenny did a great introduction. Beyond my inability to walk into not walls, I live with chronic pain, and it started to affect every aspect of my being about 5 years ago. And sort of what I'm hoping to do is not only talk about my lived experience with diagnosis and what that journey has looked like, but also how sex and gender have played into this. And so walking into some of the intersections and how they compound the challenges of getting a diagnosis, but also what it looks like to sort of walk through everyday life. So, my chronic pain started to affect every aspect of my life about 5 years ago. And if anyone can think back to 5 years ago, we were in the middle of a pandemic. A lot of things were happening. There was an immense amount of stress, and I held a lot of that in my body. And I am definitely one of those people who fervently believes in a chronic pain toolkit and what's in your toolbox. And I was in the middle of a therapy appointment one day, and my therapist stopped and said, "Have you ever thought about ADHD?" I had never thought about ADHD. I had never thought about neurodiversity, despite being somebody who works with folks with fetal alcohol spectrum disorder, or as we've said, FASD. But my therapist knew I was about 2 years into a never-ending burnout. She'd heard all of my comments about my challenges with executive function, perfectionism, obvious lack of depth perception, and sensory sensitivities. And the reality is, she never witnessed any of those things. She only heard my accounts because I would never let anybody observe any of those things. My partner is the only person who has ever seen my meltdowns, but she heard about them and she understood. And I'm a health researcher. I support neurodiverse folks. I do research on social media representation of FASD and ASD. They're very different if you've ever looked at TikTok. I have always been very hesitant with self-diagnosis. It's something that has made me personally very uncomfortable. And I think part of that is because that's the paradigm I was raised with. And so I wanted to start my journey. I looked at every single validated screening tool for adults with ADHD and then adult women with ADHD, and nothing suggested that I should go for further evaluation. But because I then thought about neurodiversity every single second of every single day, I then did screenings, again, validated screenings for ASD. And every single screening suggested that I should go for an evaluation. Now, I've been told that only neurodivergent people fixate on the possibility that they're neurodivergent. And Caitlin, as the clinician, you can tell me if that's true, but it's something that in my circles, clinicians, researchers, and other neurospicy folks, that sentence gets thrown around a lot. So I'm sticking with it for right now until you tell me I'm wrong. Um, but I think there's something else that's happening here because we're at a place where more adult women like me are now either getting diagnosed or questioning if we're neurodiverse. And a lot of that comes down to the history of health research. It wasn't until the late 1990s, until 97, that women needed to be represented in Canadian health research. So it's no surprise that millennial women like myself, who would have been kids when this shift was happening, well, we're now wondering if we're neurodivergent. There are so many neurodiverse conditions like ADHD and ASD that have historically been seen as male. And Alex pointed to this at first, like this very white, very male representation. And part of that is just we weren't in the research. Um, Research, whether it was about neurodiversity or chronic pain, it was based on men and male bodies. And so we're now starting to see what neurodivergence looks like among women and girls and men and boys. And also, we're starting to see experiences of neurodivergence and chronic pain among trans and gender diverse folks who are expected to navigate cisnormative, at times very traumatizing health systems that are not inclusive, representative, or even understand how somebody's sex, so their anatomy, their physiology, their hormones, and their gender, whether it be their identity, the norms, the roles, the institutions that they are living within, they both need to be understood. They both need to be explored and they both need to be responded to. And so when we're in health systems that can barely handle when this congruence, imagine what happens when we're talking about incongruence. It just, health systems are not made for intersections of identity. They're not made for folks with chronic pain. They are not made for folks who are neurodivergent, and they certainly are not made for folks who deviate from the standard body, which was a white male body. And while research is changing, it's only quite recently that we do see some shifts. And so, while it's starting to include women, and while it's starting to include trans and gender diverse folks, it's very minimal. And I found that it's often very white, which means that we're also not getting accurate representations of the lived experiences of racialized folks who experience additional barriers to care, including to diagnoses. And so, as I continue, I'm going to talk more about my experiences and my research. I'm a women's health research. I'm also a cis woman. And so that will be sort of the lens in which I'm thinking about these issues, and also the lens in which I've navigated my own diagnostic journey. But some of the things that really stand out to me, and Alex, you again really gave a great introduction here, is just neurodivergent conditions do have different gendered presentations. For example, girls and women with ADHD are more prone to having inattentive symptoms compared to hyperactive or impulsive symptoms that people most often equate ADHD with. Women are also more likely to display internalized symptoms like anxiety, depression, eating disorders, and self-harm. And gendered stereotypes affect all of this. In the media, it's often men who play fictional, neurodiverse, often autistic characters. We have Sheldon Cooper from Big Bang Theory. We have Dr. Sean Murphy on The Good Doctor. We have Sam Gardner on Atypical. We have a singular presentation of what it means to be neurodiverse or what it looks like to be autistic. And so what this means is that we don't have the research, we don't have the representation. And so women are underdiagnosed, misdiagnosed, and improperly medicated without their neurodivergence being recognized because they don't have stereotypical traits. And all of this is culturally coded as masculine. And when we try and pair the gendered component, like gender plus neurodiversity, and then we add chronic pain to it, well, we see even more complications. Like with chronic pain, neurodivergent women hide, mask, or camouflage their differences so they are not perceived, or so they don't risk social exclusion. Internalizing disorders, like I mentioned, around anxiety, depression, etc., they're also associated with heightened experiences of pain. And so the internalization and the pressure to mask and perform as a neurotypical person can result in shame, low self-esteem, increased mental and physical health conditions like chronic pain. All of these are very interconnected. And it's not just gender that matters. Sex also matters. Neurobiology, for instance, is really important. Neurodivergent females have an increased prevalence of structural neurological anomalies, which can lead to headaches and migraines. Some research has shown that patients with fibro who are female exhibit more neurodivergent features, and they're seeing familial links. And other chronic pain syndromes are also overrepresented among neurodivergent females. In chronic pain clinics, a disproportionate number of women carry the diagnoses of both experiencing chronic pain and either having ADHD or autism. And so we have to think about them together. The last part I'll mention about sex is that hormones are really important. They're really important in chronic pain research. We know that when there is a suppression or addition of certain hormones, that it can exacerbate chronic pain. And that similarly happens in neurodivergence. Periods of big hormonal change like puberty or menopause can make it really difficult for females to cope or use their masking skills that they previously established. And so those are big shifts in hormones, but we also see it during the hormonal cycle. All of these things have an impact. And so when it comes back to diagnosis and self-diagnosis, I hear in my research on chronic pain and women's health, all of the ways in which women have been gaslit, underdiagnosed, and misdiagnosed. And I know that when we are undiagnosed or misdiagnosed, it can be really confusing, it can be traumatizing, it can also worsen all of our symptoms. And I've been really lucky in many ways. When I went to my doctor and told her I needed a referral to an endometriosis specialist, she immediately gave me a referral. But when I went back 2 years later and said, "Can I go for an autism assessment?" she said no. And when I went back the next year, she said, "You look fine. Why would you need that?" And when I went back the year after that, she finally gave me the referral, but only with the caveat that it would be a really long wait list. Well, it was a really long wait list also to see my endometriosis specialist, but I was never given that caveat. That wasn't necessary. There's so much stigma that we're then pairing on and adding. My doctor will never understand how what I believe is autism has affected my life. She won't see the meltdowns. She won't see the task paralysis, the rejection sensitivity. She won't watch me walk into the walls of my house, which I do think I've walked into every single one of them at this point. And so while I finally have a referral, I actually am not going to know if I am diagnosed officially. I won't have an official diagnosis for at least 3 or 4 more years. There is no way I could have received a referral if I did not self-advocate, but that comes from a place of privilege. We already do that as people living with pain. It's exhausting, and it can be even more exhausting if we're neurodivergent. But the reality is, we know our bodies best. And so these intersections of gender, race, class, sex, they're all important and they're all reflective of our lived experience. And we need to push for what works best. It means sometimes we are living in a world in which we're self-diagnosing because we can't get the answers that we need in a timely way. And we just need to be able to cope with our day-to-day realities. And that's okay. We need to find ways of navigating care, and whether you have a diagnosis or not, a lot of the treatment and management and neuroaffirming approaches that I know Alex and Caitlin are going to speak to still will be effective for you. And so I hope that's sort of a validating and empowering way of thinking through the complexities and the anxiety that a diagnostic journey can bring and how these intersections interplay with it.
Thanks so much, Lindsay. And Alex too. I think that there's the validation. I mean, there's a lot of work that we do, right? As neurodivergent people, as people who live with chronic pain and other chronic conditions and or morbidities, mental health conditions, and navigating all the other juicy intersections that we inhabit. I hope that, I'm going to have a request. This didn't come up necessarily in the Q&A, but Alex and Lindsay and Caitlin too, if you have reliable resources that you're open to share in the chat, that would be really helpful so that we can accumulate them and then provide them to our attendees now and in the future. So I'm going to shift, and I know that we've sort of been leaning towards Caitlin and neuroaffirming approaches to clinical care, as well as this and Alex's experience as well. There's a lot of questions for you in particular, Caitlin, in the chat that we will get to. But first, I want to hear about how are you doing? How has your experience been? Navigating yourself, your practice, and the communities you serve.
Thank you. I mean, one thing that I was just so struck by in listening to both Alex and Lindsay share their journeys is how much that parallels what I've been hearing in the research I've been doing with young people who are navigating their own diagnostic and treatment journeys while living at the intersection of chronic pain and neurodiversity. And when we talk to these young people, we're hearing from young people who some of whom had diagnoses as toddlers, and some of whom only got diagnosed as a young adult. And what those processes of both seeking a diagnosis for their neurodiversity and for their chronic pain look like is influenced by so many of these intersectional identities and factors that have been discussed. And the timing of which diagnosis came first also seems to really play into what that trajectory ends up looking like. And a lot of young people would say, like, I don't share my neurodiverse identity with my medical providers because of the fear that they're going to treat me differently, that they're going to chalk all of my symptoms up to that one thing, that I'm not going to be taken seriously. And for some young people where that wasn't an option, the provider was already aware. There's then this sense of like, well, now I have to take an advocate with me because they're not going to take me seriously if I'm the one speaking. And I struggle with this as someone who both does this research, works in the healthcare system, and accesses the healthcare system, because I can see the harm that's happening before somebody even steps in the door. And part of what I've been really struck by in doing this work is how there's often this sense of like, oh, neurodiverse folks don't understand social interactions. When actually, I would argue that what I'm hearing from the voices of these youth is like, they understand these social interactions better than most. And they understand the nuance of what they have to do and what they have to say and how they have to be to get the care that they deserve. And that comes with a huge amount of emotional labor, of executive function, and even, like I said, just that process of getting in the door. There's so much that is involved in getting to that place that when we start to think about like what are going to be effective ways of supporting neurodiverse folks who have chronic pain, it can't just be like, what are the treatments we're providing? It's like, how are we supporting all the way up to even getting in the door for those treatments? So I just want to say how much I appreciate both Alex and Lindsay for sharing your stories, and that I'm somewhat reassured by the fact that our research is matching, like that we're, hearing what matches lived experience. And now the next really big challenge is like, what do we do about this? Because many of the issues that come up are things that, if you have a good neuroaffirming clinician, you might be able to work through some of it. A lot of this are really big systems level barriers that just cause this tension and this moral distress for providers who are trying to provide evidence-based care when what we have is a pretty big lack of evidence and a lack of systemic support in how to provide that. I don't know if that answered your question, Jenny. I went on my own tangent.
Tangents are pretty par for the course, I'd say, with us. Thank you for that. It's as you were talking about how like the understanding of youth and social situations, I could see like Alex and Lindsay both nodding their heads furiously. There's a lot of are you open to speaking about, I think in one of our previous conversations, actually, Alex, you too, we've talked about a little bit, we hinted a little bit about harms done in clinical settings. And I know that there are spaces where cognitive behavioral therapy are appropriate and spaces where they're not necessarily. And I know, Caitlin, from your own practice, you take that cognitive behavioral therapy model and you really work it so that it works for your clients. I know that some of us here have had not great experiences. And so, I'm hoping that this could be a bit of a conversation in the, I'm going to say 6 minutes that we've got before we go into questions on what is possible and where can we find these resources. It's a big one. It's a big ask. Sorry, not sorry.
I'll jump in. Yeah, I would say, so this is, I would also say too, my experiences have been shaped by the fact that I am not someone who has family who I can bring with me to advocate. I do not have a partner. This is again, the intersection. I did not have friends growing up. I have had mostly abusive and dysfunctional relationships with folks throughout my life, and thus the relationships I do have are not ones where I'm close. So I look very normal on the professional side of things. And when I describe my personal life to people, their face gets like they don't know how to process the fact that I don't see people on a regular basis. My best friend lives in the UK. My physically closest friends all live 3 hours away from me. I don't have an emergency contact when I have to go to the doctors. I certainly don't have anyone who can advocate for me. That's also literally part of the reason I can't get an autism diagnosis, is because I do not have a figure from my childhood who can speak reliably for me. So all of that is to say that I've had to really make my own solutions. And as much as I often rail against self-management, because I think the onus of self-management, when it is a tool leveraged by the clinic to delegate responsibility for caring for people with pain back onto the people with pain themselves. I'm also going to pull a quote from a book that I'm reading at the moment, which is called You Deserve a Tech Union. The author said, "We are all we have, and that is enough." And so sometimes the most progress I've made with my own care was when I've leaned into the realization that often I am all I have, and I need to be enough for myself. So I have turned to biohacking. I won't get into that because I know that's a controversial topic, and it's a risky one. It is a risk that I take on to myself willingly. But I go through social media and I use what I know of how my brain and my body work to critically evaluate what I'm finding. And so for me, it's been a lot of finding things that resonate with my experience and then trying to branch out, leveraging my ability to go down rabbit holes to then say, okay, I think I figured out what's happening in my body. And now how can I find solutions that work for me? And so it's been a lot about learning that for me, it's less about emotional regulation. It's more about sensory regulation. That was a big revelation for me, because there's so much emphasis in pain self-management on manage your emotions to manage your pain, and also manage your stress to manage your pain. And I mean, that one really gets me, because how on earth are we as neurodivergent people living under late capitalism, living with chronic pain, supposed to manage our stress levels? How is that not just punishing the victim to tell us that? So that gets me. And emotional regulation, because again, this is the intersection of chronic pain and neurodivergence, but being in pain is a form of sensory input. It is a form of sensory overload. Being an unrelenting, poorly managed pain will put you into autistic burnout. And conversely, yes, autistic burnout will make your pain worse. So you end up in this vicious cycle. And the emphasis that I've encountered so much in so-called psychosocial approaches to pain has been on managing the emotional side. But this is the thing, I'm really good at like rationalizing the hell out of my emotions. And that also costs me a lot of energy and kind of sends me into cycles of like just rationalizing my emotions more and more. And it just doesn't help. And often leads to me rationalizing really harmful situations that I'm in too, because I get really into rationalizing. So for me, it's been about leaning into somatic practices. And it's going to sound silly, but like listening to ASMR videos under a weighted blanket with the lights off, like when I start to feel that I'm becoming overwhelmed, being proactive about like just taking a 20-minute break to turn the lights off, get a weighted blanket on me, and listen to ASMR and give my brain a break from processing sensory input has been so instrumental. Pacing is challenging, but figuring out the ways in which I can fit pacing into my day in as small a way as I can manage even, and not pressuring myself to be better at it. Because again, like the stress of trying to be perfect about self-managing your pain adds more stress, which then creates more cognitive overload, which then creates more pain. So yeah, it's really been about sort of experimenting, finding, and I would say taking a sensory or somatic first approach. And I do want to shout out Desmond, who we wanted to have the opportunity to speak about trauma release exercises, because that's a modality that I've been working through with Desmond, not as frequently as I would like, because again, the demands of working full-time under late capitalism and also having medical appointments. But the one appointment I've had so far, I did find really helpful, and it's a modality that really like conceptually resonates with me as well. And also, becoming more active about stimming. I've actually felt like I've had to teach myself to stim because it's something I learned to suppress, but I've tried to become more proactive about it. And as I have become more proactive about it, I have found that, again, helping to manage the sensory overload in a more proactive way has helped to an extent with my energy levels. It hasn't fixed anything. I still need medications, need more medications than I can get prescribed for me, but it has helped.
Thanks, Alice. And we appreciate the shout out to Desmond and his somatic traumatic release exercises practice. Caitlin, we have a few minutes. I really want to hear your perspective.
Yeah, thanks so much. I think, one of the things that I find so challenging in doing this work is that a lot of time, like, first and foremost, what needs to happen is just some like very deep acknowledgement and validation of the harms that the healthcare system does cause and continues to cause, and that you can be and have a very well-meaning and well-intentioned provider, and that that provider is often working off of information and evidence that doesn't represent neurodiverse folks. And we did a review recently of this was specifically in the pediatric chronic pain research, but we were looking at what's considered the gold standard evidence for treating pediatric chronic pain with medications, with physical therapies, and with psychological therapies. And across all of those like gold standard papers, there's no representation of neurodiverse and autistic folks. And in fact, most studies are actively excluding neurodiverse young people from participating in them. So a lot of this has led to a lot of the work that my group is doing now is trying to figure out like how do we create more accessible participation opportunities for young people in health research that's really informed by the priorities of neurodiverse young people, and where we're taking a pretty strong co-design lens. because there are all kinds of things that when I talk to health research audiences and clinicians about this work, I get the sense that there's this expectation that I'm going to have some like really groundbreaking things to suggest, and the thing I always come back to is like, it's amazing how much some very small changes to the way that somebody approaches a patient, to the way that a clinic environment is set up, to the way that we might frame a therapeutic approach, how much of an impact that can have when it starts by first acknowledging the needs, the experiences, the perspective of that person. And so a lot of the time I find what I'm advocating for is like, let's start with patient-centered care. And let's start by listening to what somebody is asking for support with. And this is where I do get frustrated, and I see this coming up a lot in the Q&A at some of the gatekeeping that happens around access to diagnostic processes and clarity, because I do think it changes things. I think it lends an extra layer of understanding to how one might provide appropriate support, or at least leads to asking some of the questions that will really help to tailor a treatment experience. And I completely agree with Alex that one of the huge gaps in our existing treatments is acknowledging the sensory component that's so front and center for many neurodiverse folks. And in some data that we've been collecting recently of autistic children, youth, and young adults, we found that sensory sensitivity and sensation seeking is associated with same-day pain experiences. This is something that clinicians we don't get training in this. And most of the time, if we're thinking about sort of sensation seeking, it's something that's really pathologized. Like, oh, somebody's self-injuring. That's a thing that needs to stop. When actually what we're hearing, talking to a lot of young people, is that sometimes that what looks like a self-injurious behavior to an observer is an attempt to try and modulate and manage their own pain by providing a different sensory input. And so even just having that layer of understanding that, how a clinician or a neurotypical individual might perceive a behavior, they're seeing that through a particular lens. And without understanding, like, what is that behavior serving? How is this an attempt for that person to manage the suffering they're experiencing? We're not going to be able to incorporate that information into a good treatment plan if we don't have it. So I think there's some pretty small but impactful steps that clinicians can take. I think in the clinical and research world, we need so much more dialogue between folks who work in neurodivergence and folks who work in chronic pain, because they're not fields that have traditionally overlapped much, despite the fact that they very obviously should. And we need more lived experience engagement in all of our research that's working towards developing better treatments, because I would love to get to the end of my career and say, I have confidence that I am practicing evidence-based care because the evidence actually exists.
Thanks, Caitlin. Oh, 7 minutes. Okay, so I'm having issues trying to access the Q&A, but there was one question about, there's a lot of really great questions, some about how to address psychological trauma and distress, and how it may exacerbate their experience of pain and neurodiversity, and vice versa. And before that, I want to say that any resources that we come up with now or later, we will put in the exhibit hall. I think it's under the Pain Canada banner, so that you will be able to access that. And that includes any research that Lindsay has done, any research, or I think you've got at least a couple of YouTube videos, Caitlin, any Alex, the book that you just mentioned about yeah, go.
Oh yeah, it's called You Deserve a Tech Union by Ethan Marcotte. I can type it into chat. It's kind of tangentially related, but the vibes were relatable, I think, in a lot of ways.
Thank you. I was just notified by our tech support that we can create a specific resource section in the exhibit area, so we're not having to hunt and peck. So thank you, Carolyn, for that. First of all, I really want to thank the people who've been sharing their experiences in the Q&A. You've shared some really heavy and very meaningful and moving things about the challenges you've experienced, the fears and the despair. We hope that, again, there's no whole way, like, if we manage to somehow answer a little bit of your question, that's awesome. Sometimes some of the questions were so complex that we'd have to dive in and spend like 7 more hours to do that. That doesn't mean that you weren't seen. So, and also we will have the Q&A for us to reflect on and take back, and then we can continue to add more resources to that exhibit area section. So, I'm just looking at, was there any question that was sort of tickling your curiosity here? Oh, there was one person asked about peer support, and that's something that I can speak to. There are peer support groups sort of seeded throughout Canada specific to chronic pain. I am unaware of anything specific to neurodiversity. I do know that a number of the facilitators themselves are neurodivergent, and so they're kind of weaving that into their own groups. I know that Pain BC has a lot of affinity-based and identity-based groups. And then the Power Over Pain portal has the sort of the hub for all of the peer support groups that are being offered throughout the pain-specific peer supports that are being offered throughout Canada, such as the People in Pain Network, who is based in the Atlantic area, but is providing resources and support throughout Canada. Pain BC is very specific to Pain BC, and I can't remember the names for the Alberta ones, but they're out there. There are places where you can hang out and be. And I think that the masking part that all of you have talked about, and that many of us experience, including myself, about showing up and presenting, you know, in the groups that I've facilitated and also taken part in, some of that, not all of it, tends to be unburdened when we show up and be welcomed as we are, because these are what the support groups are made for. That's what I can say. Any last words from the three of you before we hand it off to Therese to close?
I would just jump in. I noticed a lot of questions about trauma.
Yeah.
And I think it's really important that we acknowledge trauma. And again, I'm going to go back to the intersectional lens, because there's curiosity about if trauma has a relationship with neurodiversity and if trauma has a relationship with chronic pain and all of these things. Yes. And it also has a relationship with both sex and gender. And so we cannot have this conversation without acknowledging that trauma does intersect here as well. So thank you to all those who mentioned it and who brought it to the table, because as Jenny said, this is just the first of what we hope might be many conversations. And trauma is one of those next intersections that we absolutely need to always be considering, and having trauma-informed approaches that work alongside neuroaffirming ones.
Thank you, Lindsay. Caitlin or Alex? You have 45 seconds each, friends.
In true neurodivergent fashion, I got distracted by the Q&A, so I will leave it to you, Lindsay.
I'll just say how much I appreciate being part of this conversation. Thanks so much for having me, and thanks for all of the really thoughtful questions. Yeah, I haven't been able to keep up with them, but I'm reading through them now. Really appreciate them.
Yeah, thank you. I wish that this were a neurodivergent friendly platform, because my brain is going a little like short-circuity. But like I said, thank you again for all of you for showing up. Alex, Lindsay, Caitlin, Desmond, who I know is present with us, Therese, and for every single person who's been giving us all the love bombs and applause in the chat, all of your questions, and even the ones you didn't ask. Thank you for being here, all of you. I'm going to pass it over to you, Therese.
Thank you. That was excellent. And I just want to say that a lot of the content that was mentioned may have resonated with people, and that you need to do what's right for you in this moment. If you were triggered by any of the content, and reach out. Don't go through this alone. So I just want to thank our very brave speakers and presenters this afternoon. That was excellent. And that's the end of today. We'll be back tomorrow at 10 a.m. Pacific time. I think that's 1 o'clock Eastern time. And yeah, so join us. After the session ends, there will be a short survey. If you could take the time to fill that out, please, because that helps us to design conferences that will come up in the future. And we want to make sure that the voices are heard, and that's how we do it, through your feedback. The exhibit area will remain open for resources, and the videos will be available in about 2 weeks from Pain Canada. So take care of yourselves, and we'll be back tomorrow. Have a great evening, everyone.
Thanks, everyone.